I was actually very surprised to see the new task force recommendations because they don't seem to be based on any new information whatsoever. It's not like there's some new randomized trial suddenly showing that women under 50 aren't benefiting from breast screening. We have the same studies, and the meta-analyses consistently show a mortality reduction of somewhere between 15 and 20%. The new data that we have, actually, that's come out in the last few years is the data on digital mammography. And that suggests that the sensitivity of mammography for women under 50, which was always a major problem and why we didn't see the same mortality reduction that we saw in older patients, was because screen film mammography isn't good with young women with dense breasts. But with digital mammography, there's a clear advantage. The technique is clearly more sensitive. So if anything, you would expect guidelines that hadn't suggested screening women under 50, such as we have in Canada, to perhaps change and now include those women and not the opposite. The other thing that was very unusual about the guidelines is that they suggested if you are going to screen women under 50, then do it every 2 years. But we know from lots of different data that women under 50 have tumors that grow much more quickly. So unless you want to miss a lot of cancers with screening, you really have to screen them every year. And the final thing was that the guideline committee is leaving the decision up to the women and her physician based on women's risk. Well, with the exception of a very small number of women who have an astronomical risk because they have a very strong family history or an abnormal genetic mutation, the vast majority of women who get breast cancer don't have any obvious risk factors. So we're really unable to tease out which women need screening and which ones don't. And that came through very clearly in a lot of the sessions we've had here so far at San Antonio. Obviously, we need something better than mammography that's going to perhaps find women who don't need to have mammograms every single year, women who really are high risk or women who really are low risk, and that's where researchers have to come into play. But right now, this is the best we have, and I think women should at least be able to get screening mammography every year from age 40 and have that paid for and not have to start fighting with their insurance companies or whatever. So high-risk women is one of my areas of research interest, and the way I define high risk is women with a very strong family history. And there are a lot of models now that allow you to calculate actually what that family history means in terms of lifetime risk of breast cancer. And we're talking now about women who have a 25% or higher lifetime risk of breast cancer as compared to the average woman who has about a 10% or 9% or whatever you want to say lifetime risk of breast cancer. The other group was, of course, women who may or may not have a very strong family history, but for whatever reason have had genetic testing, and they have a mutation in a gene BRCA1 or BRCA2, and their lifetime risk is well over 50%. So they're a very, very high-risk group. And these women, we know from lots of studies now, aren't screened adequately by mammography. And they're also not screened adequately by starting mammography at age 50 or even 40 because their average age of getting breast cancer is the mid-40s, not the mid-60s like the general population. So we have to screen these women at 30, even sometimes even from age 25 in certain really, really high-risk families. And what these women need is magnetic resonance imaging, MRI, in addition to mammography. They need to start by age 30, and they need to do it every year. Now, the other thing with these women is, why sit and wait and watch these women get cancer? I mean, that seems ridiculous. We want to be able to prevent the cancers if possible. And so far, the most important thing that these women can do is have their ovaries removed as soon as they've completed their families. Now, for the women with the BRCA1 and 2 mutations, this has the additional advantage of removing their risk of ovarian cancer. But even for the very, very high-risk women, this might be something to contemplate. Or alternatively, we need some sort of hormonal manipulation that simulates that. And we know that that can cut risk by at least 50%.